Hi everybody, today I want to speak about ischemic heart disease or AHD. Ischemic heart disease is characterized by the lack of oxygen. As you know, it is resulting from inadequate perfusion of the myocardium and oxygen supply for the myocardium decrease. And usually it is often because of the narrowing or blockage of the coronary artery. Usually patients with ischemic heart disease they present with chronic stable angina, okay, or presmetal angina, or acute coronary syndrome. Okay, in the emergency, when we meet the patient, in the first step, we don't know this patient has which of these problems, okay? And especially in the acute coronary syndrome, maybe patient has one of these pathophysiological problems like non-ST segment elevation, myocardial infarction, or ST elevation myocardial infarction, or maybe the patient has unstable angina. How we can understand about this? We have to see the signs and symptom. Okay, for the diagnosis, mainly we use the laboratory test, ECG, and the signs and symptoms, and also medical history of the patient. I speak about a little about the difference between the non-ST and the ST elevation myocardial infarction. Usually, in the non-ST elevation myocardial infarction, the amount of the thrombus, in the thrombus, the amount of the platelet, okay, is more than fibrin and red blood cell. And because of this, we say it is a white clot. But in the ST elevation myocardial infarction, the amount of the fibrin and red blood cell is more than platelet, and we can say red clot. Okay, usually in the ST elevation myocardial infarction, the coronary artery completely closed. But in the white clot or in the non-ST elevation myocardial infarction, usually the vessel is not completely closed, maybe partially closed, okay? It is because of the oxygen supply decreasing so much, but the vessel is not completely closed. For the diagnosis, if the ischemic like chest pain persists for at least 20 or 30 minutes or half an hour, we have to suspect the ACS, okay, acute coronary syndrome. For the diagnosis, the first step, we have to speak with the patient and the family of the patient, and we see the sign and symptom. Okay, in the sign and symptom, usually we can see the chest pain with the high pressure or crashing in the substernal area, which radiated to the left arm, jaw, shoulder, and also the back. It is very important. Maybe patient has a nausea or vomit or cold sweat, okay? Compared to the chronic stable angina, patient with the acute coronary syndrome maybe has a more severe pain also, and the symptom that does not decrease in the rest situation. And also, when we give the patient sublingual or the intravascular sublingual nitroglycerin, in this case also does not so much effect in the patient. Okay? Also, instead of these problems, maybe the patient has also heart failure problem, okay, or with or without arrhythmic problems. For these problems, for the diagnosis, we have to use ECG and blood test. Okay, in the blood test, we usually use cardiac enzymes, troponin, and the CKMB. And as you see, okay, in the unstable angina, I write here 1 star. In the unstable angina, okay, this enzyme is negative in the blood test, okay? But in the ST elevation myocardial infarction and the non-ST elevation myocardial infarction, we have a positive test for both of them, okay? Okay, it is one of the very important steps in the emergency. If you see the blood test of the patient has a positive, in this case we can see it is a non-ST or ST. Okay, and for the other step is the ECG. If you see the ECG, okay, if the patient has a ST segment depression, okay, in the ST segment depression happen, in this patient has the unstable angina, okay, in the unstable angina, okay, usually we will have a ST segment depression. Okay, it is one of the steps very important for us. But also we can see in the non-ST elevation myocardial infarction, we can see the ST segment depression. But in the T wave, if we see the T wave, we can see the T wave inversion also happen. Unfortunately, in the non-ST elevation myocardial infarction, we usually see this problem also. But the problem difference between non-ST, we have to see it is a negative in the blood test for the cardiac enzyme like troponin or CKMB. Okay, for the non-ST elevation myocardial infarction, we can see usually we can see ST segment depression or maybe T wave inversion. But the difference is it has a positive CKMB enzyme in the first hours of the after the myocardial infarction. But in the ST elevation myocardial infarction, we usually see ST segment elevation and also positive blood test for the CKMB and troponin. Under here, we understand how is the diagnosis of the ischemic heart disease, and it's very important. And in the next step, we can decide before the treatment, okay? Before the treatment, we have to diagnosis after these problems, okay? Now what we can do for the patient, okay? In the emergency for the Unstable angina and non-ST elevation myocardial infarction, usually we can use anti-ischemic and analgesic therapy. Okay? Okay, first for the both of them, usually if the patient has a high pain, very severe pain, we can use morphine. As the first step, we can use the morphine. Okay, usually the dose is the intravascular, intravenous, and 1 to 5 milligram. Okay, we can repeat it in the half an hour. And the other problem is this, that we can use nitroglycerin. Okay, usually we can give in the sublingual, but sometimes it's intravascular also. But before we give the nitroglycerin, we have to see the ECG and the heart rate and blood pressure. Okay, maybe you say it is in the for the fast helping for the patient, we have to check the heart rate and blood pressure. If the patient has bradycardia and low blood pressure, we cannot use nitroglycerin because, as you know, also this drug has a adverse effect like reflex tachycardia, hypotension, and usually it can cause a headache. It's very important, we have to think about it. But the most important problem, we have to see the patient heart rate and blood pressure. Other treatment we can use for is a beta blocker. If the patient has a normal heart rate or tachycardia or high blood pressure, we can use a beta blocker. Also here, we cannot use it for the patient with a low blood pressure. We cannot use beta blocker. Usually, it's very important. Okay, and we can use cardioselective and also non-cardioselective beta blocker. The last lecture I spoke about it, and other drug is the calcium channel blocker. For example, non-DHP calcium blocker like verapamil. We can use for the patient, but the problem is that these drugs has a contraindication with the beta blocker. Okay, these two groups, we cannot give the patient with both in the situation, both of the same. Okay, also we can use a long-acting non-DHP calcium channel blocker if you see who have a recurrent ischemic, okay, and no effect with the nitroglycerin and the beta blocker treatment on the next step. Sometime in the patient, for example, for the diabetic patient or some the patient, we can use ACE inhibitor for the decrease peripheral resistance and decrease vascular effect of the hypertension. Okay, usually we should give the patient in the 24 hours with the pulmonary congestion, or if the patient has the contraindication with the other drugs. Okay, for example, if the patient has a diabetic mellitus or the kidney problems. And the next step after the treatment, if you see, we can use the antiplatelet therapy. For the antiplatelet therapy, the first step is the aspirin. Okay. Aspirin is the COX inhibitor, and it is usually we give the patient with the ischemic heart failure in the little higher dose than 80 milligram. Usually we give the fourth patient is around 182 to 325 milligram. If the patient has a chest pain, okay, and also in this case we usually give the other medicine which called clopidogrel. This is important if the patient has a stomach ulcer or bleeding in the GI tract. We cannot use mainly aspirin. In this case, we can use this medicine, or other medicine we can give for the patient is the GPBS, or we can say glycoprotein 2B 3A receptor blockers. Okay, these drugs also we can plan for the patient. Okay, and mainly clopidogrel and GPB can be initiated prior to the angiography. Okay, in this case we can use these drugs also, and also if for the occlusion of the vessel, for the blockage of the vessel or the narrowing vessel, sometimes if we know sure it is because of thrombus, we can use anticoagulant. Okay, therapy, for example, like unfractionated heparin, for example. Heparin. It is for this treatment is we usually use for the unstable angina and non-ST segment elevation myocardial infarction. But if we want to treat manage the patient with the ST elevation myocardial infarction, as you see in the ECG, we see the ST segment elevation. Usually we can start for the high pain, we can use the morphine, as like before I spoke about the non-ST and unstable angina. Usually we can use a nitroglycerin and a beta blocker. Okay, and we don't use the calcium channel blocker, and also we can use ACE inhibitors. But mainly treatment we try to the antiplatelet therapy like aspirin and the clopidogrel and also GPBS, glycoprotein 2B 3A receptor blockers we can use. Okay, and also within the ST elevation myocardial infarction we can also use fibrinolytic therapy. Okay, because in this case we have to use in the patient presenting into the hospital. Okay, we need with this therapy, and we have to monitor the patient. And also we can use anticoagulant therapy, okay, for the system. Usually we can use heparin or enoxaparin or fendaparinix. It is one of the important things that we can use, okay? But mainly if we, after the patient, for example, if angiography, or we use a stand or after the first step, for the secondary prevention of the myocardial infarction, usually we have to use aspirin, clopidogrel, beta blocker, and ACE inhibitor usually we use. But mainly we have to check the heart rate always and the blood pressure. Okay, and we can use ACE inhibitor also in these patients, and sometimes we have to use aldosterone receptor antagonist. It is depend for the, but mainly also we use the statins for the decrease cholesterol, and is one of the important things in the patient if we sure the patient has these big problems. I hope this information about ischemic heart failure, ischemic heart disease is useful, and I hope see you in the next lecture.